pediatrician and work both as head of the EPI unit in IVB in WHO in Geneva and as a deputy in the COVID delivery partnership. And as such, we've started this learning collective, and I'm really grateful for all of you showing up today to this session. I will first leave it over to Santosh to go through some of the detail on the logistics around this afternoon. And warm welcome again.
And thank you very much, and warm welcome everybody. Just to start, a few housekeeping slides. If you can scan the QR code on the screen, or even click the link on the chat. There is an icebreaker activity just to kind of get familiar with a few questions as an icebreaker activity. So next slide, please. For the interpretation, we have available in English and French, and you can click the interpretation button on the right-hand corner of the screen, and you can choose the language you wish to hear, whether it's English or French. Next, please. We also have the live transcript, and if you you just go to the screen on the live transcript, and then you can see the subtitles. If you want to kind of show the subtitles or hide the subtitles, you can use the function accordingly. Next, please. For the Q&As, please, while the presenters are presenting, if you have any questions you want to post, please post them in the chat. Also, at the end of the session, after each country presentation, we would be opening the floor for Q&A. So please raise your hand for any question and answers that you have, so that we can have a discussion based on the questions that you have. Next one, please. So for the recordings of the certificate, the session is going to be recorded, and your attendance is the consent to be recorded. The PowerPoint will be available, and I will, towards the end of the session, I will give you details as to where the resources are located for you to access. And there's also a certificate of attendance that will be issued by the University of Mexico and I will talk also about this towards the end of the session. Next, please. And for the data use, Project ECHO would be collecting registration, participation, Q&As, chat and comments, and poll responses for some ECHO programs. So your personally identified data would be shared with the project funder, and this may be used for reports, maps, communication, survey, quality assurance, evaluation research, and to inform new initiatives. I think this is my last slide. Can you go to the next one, please? Over to you, Anne.
Donc, bienvenue, welcome everyone, warm welcome. So I'll just show just a few slides here on just backing up where are we in the COVID-19 vaccine delivery in worldwide, and then a bit of the purpose and the agenda for this afternoon. But I would like you to be very, very active on the chat. And as you can see in the chat right now, you have also a link to the Telegram group, which I really encourage you to join so that we can continue the conversation in between these sessions. Next slide. Quickly, almost 12 billion doses have been administered globally of all the different COVID vaccines that we have in circulation at the moment. 4 billion of those have been administered in AMC participant countries. And as you know, the COVID delivery partnership are focusing, particularly working with the 34 countries that at mid-January were below 10% of coverage of the primary series. Now, 18 are still below 10%. And we have decided that this collective, we hope that we'll be able to share with you and discuss with you along these next series of learning collective on best practices. How can we reach fast a better coverage in the countries that have still struggles of rolling out the vaccines? Next slide. So if you look at this deck here, it's from January and until May. If you look at the dark blue, the number of countries have decreased from 34 to 18 below 10%, and the increase in coverage in the same 34 has gone from 3 to 10%, 3.3 times coverage. So there is a huge increase and lots of attention here and lots of learnings that we can share across the countries available and present on this call. Next slide. So what we wanted to do, the objective of this Learning Collective initiative, is a peer-to-peer learning between the 34 concerted support countries together. There will be other AMC participants as well, but particularly collect, consolidate, and share lessons learned, best practices, and challenges across these 34 countries. We also would want to cultivate a community of peer-to-peer learnings from all of us. We've been on a learning curve the past 2 years, but here is a direct connect, speak to speak, country to country, peer-to-peer on how to maximize the learnings from each one to increase uptake quickly. So the audience here is primarily directed at national authorities and at pretty high level of coordinating and responsible of national government officials across the 34 countries. And then second target audience would be partners as well, supporting the one country team. Next slide. The planning is that we will have 6 sessions, the first one today, and then the other dates you have across. It will be 90 minutes for each, and we'll have a detailed topic for each one of them that will be sent out 1 week prior to each session. We would really like to welcome participants to share country experiences. So if you are interested and would like to, at any of the sessions above, join us and share your experiences, we very much encourage that and hope that you would be willing and wanting to share your learnings and your best experiences. Next slide, and your struggles, actually. So today we have a presentation outline where next we'll have an overview from the ECHO model. We'll have Shalini speak about priority groups, and then we have, most importantly, representatives from Sierra Leone and Burkina Faso who will share with us 20 minutes each. So now I will go to the next slide. I hope you'll all have a very intense and good afternoon. And please, again, use the chat really actively for sharing, commenting, discussion between you and all of us actively. Over to you, Santosh.
Yes, thank you. And before we get started on the session, just an icebreaker activity, just to get a pulse in terms of the level of participation and where the participation is coming from. If you can go to the next slide, please. If you could scan the QR code on the screen, or there is a link in the chat. If you can just click the link in the chat and just follow the questions over there in terms of what organization are you joining from? Is it from the Ministry of Health? Is it from the UNICEF, WHO Regional Country Office? Is it from the Gavi? Or there is the first question on that. And the second, in terms of which country are you joining from? And then the third question in terms of the challenges, the themes around the challenges that the country that you're participating from in terms of the challenges they're facing with the COVID-19 vaccination. So if you could click the link and fill out this very quick survey to get an idea of the responses, that would be much appreciated. Do we have the link in the chat? Yes, thank you. And if you can go to the next slide, we can just get an idea of the responses of the expected level of participation. So we have participants from the Ministry of Health, also from the country office, and from the regional office and the headquarters, Gavi, from NGOs, but also independent consultants and other colleagues. Next slide, please. In terms of the level of participation, we can see this is a mapping exercise is to see the level of participation in terms of where the participants are coming from. We can see participants from the headquarters, but also see from different countries in Afro, some along the Western Pacific region, and then also some from the US. So this is the level of participation in terms of geography. Next one, please. So in terms of the third question that we had was your day-to-day challenge in the past month that you've been facing, so that we can kind of cater the themes in the next upcoming sessions around this level of discussions. I think majority of them in the past month, they feel that there is the challenges that mainly around planning, coordination, and service delivery, but also around demand generation. So, around monitoring and evaluation and supply chain and waste management.
Good.
So this is good because in the upcoming sessions, we would be having sessions based on the themes around demand generation, but also around integration of activities around COVID-19 vaccination, but which I would talk to more in the end of the session. So with this, I stop here and over to you, Anne.
Thank you. So we see that the poll still popping up, but let's go to the next slide. And Ted Shaban, over to you, the global lead and coordinator of COVID vaccine delivery partnership. Over to you.
Thank you. Hello, everyone. My name is Ted Shaban. I'm the global lead coordinator for COVID-19 vaccine delivery. And it's a pleasure to have you at this session. This is the first edition of what we hope is an ongoing learning collective, a series hosted by the COVID-19 Vaccine Delivery Partnership and Project ECHO. The COVID-19 Vaccine Delivery Partnership, or COVDP for short, was launched as an interagency partnership by WHO, UNICEF, Gavi, and other partners in January 2022 to support the 92 advanced market commitment participants in accelerating vaccine rollout, with a particular focus on the 34 countries Anne was speaking of. Those were the 34 countries that were at 10% or less vaccine coverage in January 2022. A key principle of our partnership has been to be country-led and build on the existing resources, experiences, and expertise at country level. And this learning collaborative is part of this approach to provide a space to share experiences and knowledge beyond your country. Over the next few months, we're hoping that this learning collective will provide a forum for countries supported by the different partners to share good practices and challenges, strengthen our communities of practice around vaccine delivery, learn from each other's experiences, and collectively solve problems around some of the biggest challenges that we face in accelerating vaccine delivery. It's a simple idea. How can we all help each other understand what approaches and strategies have worked or have not worked so well in increasing vaccine uptake? What are the reasons for success or failure, and how can we do things differently to turn vaccines into vaccination? And I hope we can equally be comfortable speaking about success, but also challenges. I think it's important that this knowledge we're speaking of contribute to progress, and we have shown that progress is possible. As Anne has said, 16 countries have now gone beyond 10% vaccine coverage, with places like Ivory Coast, Uganda, Ethiopia, Zambia, Solomon Islands actually going beyond 20% vaccine coverage. We want to make sure we capture and share lessons and best practices across practitioners from these different countries as they work towards their national targets, in turn towards the global vaccination goals. And some of the questions we're grappling with: how to reach high priority populations, how to best plan vaccine supply and demand, which vaccination strategies to choose, how to engage with communities and community leaders and deal with vaccine demand and vaccine hesitancy, are some of the topics that we hope we will have at this learning collective. In the first session today, we'll learn from Dr. Linda Farmagrand from the Ministry of Health in Sierra Leone and Mr. Zongo Amidou from the Ministry of Health in Burkina Faso about their approaches to identifying and targeting high priority groups. Thank you very much for joining today, and we very much look forward to learn from you today and to have a great discussion. Thanks, Anne, and back to you.
Thanks, Ted. Very good introduction, and bienvenue à tous who have been reaching us a little bit later. We now leave over to Amy to give us a short update on what is ECHO. Over to you, Amy.
Great. Thank you so much. It's a pleasure to see everybody here today. My name is Amy Groom, and I'm the Director of Immunization Initiatives with Project ECHO. We're based with the University of New Mexico in the United States, and we're really delighted to be here today to support the COVID-19 vaccine delivery partnership with this Learning Collective initiative. Next slide, please. For those of you who may not know much about ECHO, it's a case-based learning model which supports virtual learning communities. And as Ted mentioned, the purpose of this is to really bring together some of the subject matter experts, but also the presenters are from the countries and sharing the best practices. So this really allows for case-based learning and sharing of best practices that we can use to monitor and evaluate outcomes. So we really encourage all of you to be very active and so that we can all learn from each other. Next slide, please. As you can see from this slide, the ECHO model is currently used by over 600 partners, including ministries of health, the World Health Organization, and healthcare systems and professional societies, including many in Africa, to support over 2,000 ECHO networks in over 55 countries to address a wide range of clinical, public health, and educational activities. I'm sure many of you joined the WHO COVID vaccine rollout series that ECHO helped us support, and we're really delighted to build off of those webinars to establish this more interactive learning collective moving forward. If you want more information, we'll have a link in the chat that you can check out the ECHO program, and we look forward to participating and learning with you. Thanks so much. Back to you, Anne.
Thank you, Amy. And it's been a very good collaboration with ECHO so far during this pandemic. Over to you, Shalini, to present yourself and the first short presentation before we go into the country studies.
Thanks very much, Anne, and thank you for the opportunity to be here with everyone today. Next slide, please. So just by way of background, the goal of our COVID-19 vaccination program globally is to optimize impact against severe disease, hospitalization, death, and to protect health systems. The objective of these sessions, as you've already heard, is to learn more about how countries have designed their COVID vaccination strategies to reach their priority risk groups. In this presentation, I'm going to use older persons as an example for different strategies. And we'll go through a little bit of background, some considerations for strategies, as well as a little bit of information about vaccine uptake, knowing that there's going to be there'll be another whole session on vaccine uptake. Next slide, please. So this slide, hopefully you're all familiar with because it comes from our WHO dashboard. And on the left-hand side of the slide, what you see are the number of cases. In orange, the number of female cases, in purple, the number of male cases. The important piece here is that the majority of cases is within the age group of 20 to about 59, 60. If you take a look on the right-hand side of the slide, you can see that disproportionately the number of deaths that are occurring are in individuals over the age of 50 to 60. Just a reminder that this data is continually being generated and therefore being cleaned. So for the most up-to-date numbers, head to our website. But this is why older adults are considered one of the priority use groups. Next slide, please. So this is a bit of a busy slide, but we're just going to walk through the important pieces. Globally, there has been an astonishing effort around COVID-19 vaccinations, with over 12.3 billion doses of COVID-19 vaccines having been administered. 58 countries have vaccinated more than 70% of their population. And as you can see from the slide, people have been working really, really hard. And so the question really is, how do we target the work that we're doing? Next slide, please. This slide shows the number of older adults being vaccinated. And I'm actually going to draw your attention to the table in the right corner that shows the percentage of older adults with a complete primary series across different AMC groups by region. And what you can see is that there's a range of coverage that ranges from 30% in Afro up to 84% in the PAHO region. And as a global average, it's 64%. Next slide, please. And so what can we do in order to enhance our ability to reach individuals who are older adults, because we're not reaching all of them as yet. And as we saw, the major burden of disease is in older adults. So we need to be country and context specific. So consider the feasibility, the compatibility, acceptability to users, caregivers, health and care workers. Meet people where they are. So we want to minimize barriers and ensure that there's accessibility to the site, and wherever we're offering vaccines, it's safe. So for those, for example, who aren't as mobile perhaps, or have impairments in their vision or hearing, they're able to access our vaccine sites. It should be a person-centered approach, so being able to offer care to each individual. And then finally, we do want to be able to have a COVID-19 legacy that allows us to use the COVID-19 investment and the vaccine rollout experiences to strengthen immunization programs overall, especially as we go into the IA 2030, and we think about life course vaccinations. So there are opportunities for integration. Next slide, please. So this is a bit of a busy slide, but what I want to draw your attention to is that there are a number of different strategies that can be used in order to reach older adults. These include ones that we traditionally think about, which would be fixed sites. They also include things like residential homes where some of our older adults may reside. There are community-based strategies, outreaches that we can use, mobile clinics that might even be able to go home to home. And then the last type of strategy that we have listed here anyways is related to mass campaigns. Across the first row, you can see, across the first column, I've listed out a few of the considerations that could help as one is planning for using each of these different strategies. So how accessible would each of these strategies be? What is the community mobilization that would be needed? How does the vaccine supply scenario differ? How does the cold chain need to be modified? Are there integration opportunities? And then finally, cost. I'm going to move to the next slide because I know that in our examples, both countries have addressed some of those concerns. So the last thing I want to talk about is what drives uptake. We've talked about some of the strategies and the practical issues, but actually the behaviors and the social drivers are what's going to help us get to and reach the people that need these services the most. Next slide, please. And so while the last slide gave just a bit of an overview in terms of framing, this tree of interventions provides actual examples of how we would be able to use our strategies. So being able to have a trusted community champion, having quality and accessible services, tailoring the information that we provide as well as the services we provide, having supportive structures and policies in place, and all of that being rooted in political commitment, strong health workforce, and behavioral data that can help us improve how we target is helpful. Next slide, please. So in summary, high-risk groups such as older adults may need targeted strategies, and which strategy will depend on the local context. Vaccine uptake can be enhanced by improving accessibility to COVID-19 vaccines. This series will provide an opportunity for countries to share the strategies that they've used and have helped facilitate their ability to reach hard-to-reach populations. Other priority groups besides older adults can also benefit from these tailored approaches. And WHO is in the process of putting together further guidance to vaccinate older persons against COVID-19. And so that chart that you saw will be included in that. Next slide, please. Thank you. I'll hand it back to Anne.
Fantastic, Shalini, and who's working in the EPI team in WHO in Geneva, and are also working on summarizing all these learnings for new guidance on how to reach the elderly with COVID-19 vaccines. Thank you so much. And now we're going to move directly into the country examples. And I'm so delighted that we have two strong case studies that we will hear about today of how to identify and vaccinate priority groups. And first of all, we have Sierra Leone out. So Dr. Linda Farmergrant from the Ministry of Health, please present yourself, and you have 20 minutes for this presentation. Just to make sure as well that everyone knows that you have interpretation. So on the lowest bar here, you have a globe and you can choose your language. We also want you to be very active and comment on the presentation. Give questions all along the presentation. We want there to be very much activity in the chat. So warm welcome everyone to contribute. And over to you, Linda.
Thank you very much, Anne. So I'm Linda, working with the Ministry of Health, the Child Health and Immunization Program. Good morning. We are just like 2 minutes to the afternoon from Sierra Leone. Well, good afternoon. Next slide, please. So next slide, this is just to say Sierra Leone, government of Sierra Leone. Next slide. So this is the outline of my presentation. Next slide. All right, so I need not go over much. Everyone know where Sierra Leone is in Africa, the west coast of Africa. So our population is 8.4. And for the COVID vaccination, our target population, which is above the age of 12, makes up like 65% of the entire population, which is about 5.6 million people. And we started our COVID-19 vaccination on March 15, 2021. Next slide, please. Next slide. Next slide, please. Thank you very much. So as you can see, as of May, we have received over go back one slide. Go back to the previous slide, please. Hello. Thank you very much. So as of May 25, we've received about 4.4 million doses of COVID-19 vaccines in country since last year, March, when we started. And the country has utilized so far 3.1 million doses of the vaccines received. And in the pipeline, we have about 1,140,000 of Johnson & Johnson to be received. So the graph on the right-hand side, on my right-hand side here, so you can see that when we started, it was very, the coverage was not very high, but then we implemented some strategies, which I will show you in the previous slides, in the next slides, as how Sierra Leone was able to have a very high peak in coverage as the months went by. So you can see that we actually picked up since December 2021, and since then we've just been increasing in our coverage. Next slide, please. Next slide, please. The next slide, please. Thank you very much. Thank you. So this is it. So, sorry. Can you go back one slide, please? Thank you. So as of the 25th of May, 2022, we have 2,392,628 individuals have received at least one dose of the vaccines, which gives us a coverage of about 42.7% of the target population, which is our target population is 12 years and above, and which makes 28.8% of the total population. So that is for one dose individual, for those who receive one dose. And we know that to be fully vaccinated for some candidate vaccines like the AstraZeneca and the Pfizer, you need to have 2 doses. So for those that are now fully vaccinated in this context, as we're saying, which is 2 doses of AstraZeneca and then the Pfizer, and 1 dose of the Johnson & Johnson, 29.7% of the target population are fully vaccinated, and 19.6% of the total population are now fully vaccinated according to the standard sets. So, and for these ones, for children, which is like 12 to 17 years, because they are now part of the target group from 12 years upwards, 167,584 children have been vaccinated so far since lowering the age in December. And for the booster doses provided, we've had 8,703 individuals taking their booster doses. That is after you're fully vaccinated with your 2 doses, you are now qualified for booster doses. So 8,000 people have taken their booster doses. So 69.9% of all individuals with at least 1 dose are now fully vaccinated. So the surge campaign, the graph on the other end, so which is why we are here to say, how did Sierra Leone, the previous slide I showed, you saw the graph on the right-hand side, which showed the peak. So now we are talking about how did Sierra Leone manage to have that increase? What are the strategies that we implemented? So you can see when we started, it was just with a fewer team when we started in March 2021. By then, because the vaccines were like not much in doses, so we had to prioritize, and the strategies we used by then. So in May, we can see that the coverage was really, really low. And then we started to implement the surge strategy, which is like having increasing the teams of vaccinators doing outreach and fixed at the same time. And we started to pick up around August, which is when we increased the team and started having the surge, which is like a campaign. And in November to December, between November and December, again, we can see. So whenever there is no surge, we can see that the coverage is not a little bit high. So we see that for Sierra Leone, the surge strategy, which is like a campaign, as mentioned by the previous speaker just now, that also campaigns can be a way of reaching your target or your priority groups. So we've seen that the surge strategy, which is campaigns, are also a great way wherein we make all of our increase in coverages. So in Surge 2, we increased the team to 299. At first, we started like about 72 teams. And then when we see that we are gaining ground in this, we said, okay, let's increase our teams. Of course, the increase with teams goes with increased financial implications as well. It's not just as easy and as straightforward. And so in February, we can see the increase in teams, and since then have given us sustained increase in coverage. Next slide, please. Yeah, so this was the approach we used in identify our priority groups and the strategies we use. So we started in March, like I just said, and that was like phase 1. So we first targeted healthcare workers and also the aged population, because by then the data that was coming in, we know the aged were the one, and even from the previous slide shown just now, we see that the mortality was more in those above the 50s. So we targeted those ones in phase 1, and also healthcare workers were at high risk of having the infection while caring for those who are, and also because the supply of vaccines by then were not enough. So we have to have phased approach and also have priority. The supply was very scanty, as you can all attest to that. So that was our phase 1 and our phase 2. It included healthcare workers, and we used the fixed strategy in hospitals, so that we targeted all the hospitals, which we know healthcare workers come there to do their work, and we vaccinate them. And also the 60 and the comorbidity, we also use the fixed and also the mobile strategy, which was to reach them. And in phase 2 as well, we targeted the military, and the phase 1 was healthcare workers and the aged, and phase 2 was now this same group of people, and then we added the service, the military, the teachers, and the police. So we had to extend the teams by then, which was now like phase 3. You have to extend the teams to 299, and then we extended our services to the to mobile outreach. They were going to the military barracks, the police barracks, etc. So that was, and then in phase 3, we now included the population of above 18 years. And also we used the same strategies, mobile outreach and fixed, and then we expanded the team. So as the phase we are adding priority groups, we are now also expanding the team because the workload was getting increased. Next slide, please. And also just to let us know that this was not just happening in Freetown, which is the capital city. This was also happening at the sub-national level. Whatever strategy is being used at national level is being replicated at the sub-national level as well. So phase 4 was when the general population was now included. And at this phase, you can all agree with me that by then we had an increase in vaccines. The vaccines were now, the supply was increasing. And also the data that was coming in informed our decision, the NITAG, to come up with a recommendation to the Ministry of Health to have the age lowered to 12 years of age, 12 and above, from 12 and above. And this decision or this recommendation came in December 2021, last year. And so at this phase now, by the time you include this age group, you know, this as you can see, this is almost 65% of our population and our school children. So we had to massively expand our team from a team of 299 to now 1,385 teams, which covered all the PHUs. So it was now at district level, each PHU had a team that should go in their community, and you have the mobile teams, the static teams. These breakdowns are all given. And this was happening now at chiefdom level and at PHU level, because you have schools all the way down to those levels. Next slide. And just to say, the composition of the team, as someone may want to ask. So we had 2 vaccinators per team, a team comprised of 2 vaccinators, a recorder, somebody that will screen the patients as they come, and then a data entry, the one that will enter this data and then issue them the vaccination card. And we had a mobilizer, otherwise known as a crowd controller, which when these people are lined up, can ensure that they are distanced apart when it all started, and we'll call them one after the other to be screened and to be vaccinated. So now, what are the best practices? How did we come about the strategies and what helped us? It wasn't just as easy as I'm saying now, but a lot of work went into it. So for the leadership and coordination level, we had a regular COVID TWG meetings at the national level, and which was also replicated at district level. And also we had a periodic review of the COVID-19 deployment plan. As changes were being made, these plans are also updated. And also the establishment of strategic documents like guidelines. So whenever there's a new vaccine, then we have to update the guidelines and for healthcare workers. And also whenever there's a recommendation from the NITAG, these guidelines are at the same time updated. And also we had to involve and develop health development partners right from the start. So our TWGs are full of partners, civil society, and Ministry of Health, etc. And then the use of the NACOVAC and the DCOVAC. Now the NACOVAC is the National Coordination, COVID Coordination, and the DCOVAC is the District COVID Coordination Committee. So this was established, and we learned this right from the Ebola. So it was just replicated for the COVID. So, and also it has people that had experience from the Ebola era. So these same people were also asked to be part of the NACOVAC so that they can use their experience and to guide the Ministry of Health and to work together with the Ministry of Health. And this coordination group was also replicated at the district level to also do likewise. So that is for the leadership and coordination. And for the DCOVAC level, I may say, at that level, they involve all the stakeholders, the politicians at that level, like councillors, the religious leaders at district level, and the stakeholders like the groups, like the market women, all these little associations like the bike riders, priority groups as well were included in there. So that was one of the successes, involving the stakeholders, the traditional leaders right from the start. So made us to have these gains. So for logistics and supply, there was an assessment also that was done both at national and district level. We all know the temperature requirements for Pfizer. So we had to do an assessment at district level. So we should have the ultra negative and cold chain as well. So, and also because our capacity at national will not be enough, so some district, bigger districts were identified so that to increase their capacity so that they can store some of these vaccines there at district level. Next slide, please. So for service delivery, like I said, we use the chiefdom supervisors, the healthcare workers who are supervising the chiefdom, relevant stakeholders, even right from the start at the micro planning for their district, so they were involved. We had pre-engagement also of partners. So anytime we're having the surge, like I stated, the surge strategy, which is like a campaign, also we have to involve partners both at national and district level and the planning, in the planning phase of the surge. So everyone is on board when there is a surge because it's a nationwide activity. And also the implementation of the surge strategy, which I've just stated. So we conducted daily debriefing as well. When these surges are on every day, the supervisors and partners gather at the DHMT, which is at the district level, to talk about the surge, what went well for that particular day and where there are gaps. So this is addressed the following day immediately, not waiting until everything is over. So for risk communication and demand creation, the community-led action approach is being used in some districts throughout the deployment, through the deployment of mobilizers. So they involve the communities, and also the movement plan of these mobilizers and vaccinators are coordinated. So they will they will mobilize a particular community and inform the vaccinators to go there. So they don't miss each other. So this was one of the strategies as well. And of course, engaging as well social media, the radio and WhatsApp and Facebook, etc. Next slide, please. So for vaccine regulation and the safety, the AFI surveillance, the use of the 117 platform in the report. The 117 is a telephone, free line telephone directory that you can call and report if you're having issues. So this was used if patients are vaccinated and there are issues, they can call and they can be connected to the district and action can be taken. And also the regular NITAG meetings also helped for these AEFIs if there are issues with the vaccines or these cases are discussed and to see whether it is coming from the vaccines or these are just coincidental as the case may be. For the M&E, so there was real-time COVID-19 data entry by vaccination team at PHU levels. So they were using their Android phones, vaccinators or the data entry clerks were using their Android phones that as soon as the patient is vaccinated, the data for that patient is entered directly into the DHIS. And also the establishment of Google form, Google reporting form, Google Sheets to provide daily updates to the national level. So we asked all supervisors to fill in a Google Sheet so that we can track what are their challenges at district level, and this can also analyze on a daily basis at national level, and it's reported to the district for immediate action. Next slide, please. So for the challenges, those were all the good things about Sierra Leone. That doesn't mean we didn't have challenges as well. So the coordination is never an easy thing. So there are usually delay in the provision of resources to fund the vaccination deployment and also for the surges. And also the supplies of vaccines sometimes can be delayed as spoiled. So these also delay because it's when we have the vaccines that we can plan the surge. So there's usually—
So Dr. Lydia, you have 2 minutes left.
Okay. So, and
Fantastic.
then the suboptimal coordination between the NACOVAC and the MOH. And for the logistics and supply chain, which is very important, we have inadequate infrastructure to accommodate cold chain, and also there's lack of cold chain equipment in some PHUs. And if we are to go routine for COVID-19, we need to address these cold chain issues. And sometimes there's inadequate distribution of vaccines, and from the national, there is delay from national to distribute to the district. And also the vaccines that we receive, this is very important, sometimes have a very short shelf life, like 2 months. So we are usually under pressure to utilize these vaccines. So this is where the delay comes in as well. And there's also lack of real-time stock reporting tools. Next slide, please, as I wrap up. So service delivery, the micro plan was at some district had issues. It wasn't comprehensive. There is limited duration for training vaccinators, the heavy workload on vaccination teams, and hard to reach areas. We have a lot of riverine communities in Sierra Leone. So there's sometimes difficulty to reach those communities, and also the inadequate and maldistribution of partners. Some partners there are a lot of partners in one district, and there may be no partner in some district to help. And also the risk communication aspect, there's inadequate engagement of special groups, insufficient community engagement, weak coordination among the partners at the district level as well. Next slide. So the AEFI, there is inadequate reporting, there's inadequate response as well. And for the M&E, we have a lot of data backlog because we don't have enough data clerks to enter the data, and we don't have tablets at each level to enter the data. So we have millions of data that has not been entered into our DHIS. And a lot of paper-based are being used, and it leads to a loss of information. Next slide, please. So next steps, we want to scale up the best practices. We want to use the surge strategy to increase to at least 66% of the target population and of total population. We want to prioritize our data entry because it's causing a lot of problem, and we want to develop policies and guidelines for integrating the vaccines into routine. And we want to continue to mobilize resources to strengthen immunization and COVID-19 vaccination. Next slide. And I want to say thank you very much for listening and for inviting us.
Wow, Dr. Lydia, I am so impressed, and I can see in the chat that I'm not the only one. This is really a fruit. You can see the progress here is a fruit of really dedicated, engaged, coordinated, intentional work on getting the job done. So absolutely extraordinary presentation, I think. And I would like to remind you all that in the chat, you can say, you can put your questions directly, and I will cite a few of them that has already come in. But you can also raise your hand in the participant list, right? So raise your hand. I don't see any hands up now, so I will read 3 questions to you, Lydia and Linda, and we'll get going with the discussion for the next 10 minutes. So first of all, from Burkina Faso, Dr. Georges, you've questioned and you were asking about the campaign. I was wondering, so the question goes, in the campaigns, were you targeting priority groups, or was it really more blanket reaching the general population? And then Diana Chamblon was asking about, is there any discussions on mandated vaccination, or has that been one of the pieces? And then also Shalini was asking, this expansion that you did from phase 1 to 3 with fixed and mobile, and then very quickly go to search in the campaign mode of more than 100 and almost 1,400 teams. How did you do with the increase? Where did you get your healthcare workers from? So while we're waiting for more hands to get up, can I leave to you, Linda, to respond to those 3 questions? Was the campaign targeted, mandated vaccination, and how did you get the hands?
Yeah, thank you very much. So like we started by then, it was just targeting those priority groups. And when we expanded, we also targeted them, but this time it's also now opened to the other age groups or to other groups. So they are also prioritized, but it's now open because as vaccines are now available, we don't also want the vaccines to be wasted. So we had to open it up to reach other groups as well. So yes, they are also targeted. And for the mandatory vaccines, at first when it started and when cases were really high, yes, it was mandatory to even enter government building, to enter commercial places like the banks. You have to show vaccination. So we saw a huge turnout, people coming and asking for it. But as the rules are getting, the cases are going down, people are letting their guards down. But it's something, when we have the interaction review, it's something that the coordinators and us are also asking, that if we put again the mandate, but you don't just sit and do it, you have to also involve other stakeholders into that, making that decision. But it's something that we are also looking at it to impose it as well, and also to increase our vaccination. But on the whole, they are doing well, because, and the other thing is, when the surge is not on, you have very few people coming for vaccination. So it's only when the surge is on, like you go and meet them in the community and they now come out. But just for them to walk into the healthcare facility is very difficult. It's happening, but it's very difficult. And if we are going to wait for that, it will take us ages to have our coverage. And also for the team, the expansion, the question was asked, where did we have 1,500 healthcare facilities in Sierra Leone. That is the PHUs. So we ensured that a team from each facility had team as well. So, and then we had some teams covering all other facilities, like multiple facilities. So that is where, at first, we didn't involve all of them because the finances were not there and the vaccines were few. But now we have the vaccines, and we have expanded our target. We now have to involve all the health and the PHUs, because it's closer to them to go to their chiefdoms. Can I take the next set? Thank you.
Yes, it was also, where did you find all the healthcare workers in this very rapid expansion and also the searches?
And so we had, like I said, at first we didn't use all the healthcare workers that were at these facilities. It was just limited to the district level when we just started. So when we now expanded, the healthcare workers are there at these facilities. We just now have them involved in the team, and they are the ones that go, yes. So they were there, just that at first we couldn't spread out like to those facilities, because by then we are targeting priority groups. So we only had few at district level who could go to these priority groups. Now we had more vaccines, so we now actually told each PHU to have a vaccination team, which are the very vaccinators which are there at normal times, and also adding mobile teams to them.
So you're also so you're actually using the existing workforce. They must be exhausted. If you look at every 2 weeks, you have a surge, but you have so many good practices here on involving the chiefdom supervisors and have the daily debriefing with the digital entry of data, even if there are challenges. Now we have a hand up from Dr. Udemweze. Please, over to you. You can unmute yourself and come on to ask your question.
Yes, good afternoon from the Gambia. Mine is not a question. The Gambia and Sierra Leone are neighbors. You just also thank Sierra Leone for the wonderful COVID-19 activities they are doing in the country, and also to briefly also share one or two experiences in the Gambia, although we are not scheduled to present today. In the Gambia, we also have a weekly TWG meeting where MOH and partners attend. UNICEF, WHO, World Bank are the main partners in the Gambia that support COVID-19 vaccination. As at 30th of May, yesterday, we have vaccinated up to 486,148 people. Among these numbers, we have two strategies we use to achieve these numbers. Campaigns, we have done 330,211, the balance of 155,000 plus. We achieved it through routine strategy. In the Gambia, we noticed when we did our interaction review that vaccination campaigns will give us a better strategy to reach out to the population at risk, because we noticed that among the challenges we're having then was the low uptake of vaccine among older population. So once we started to engage the campaign strategy, we had a surge in the number of people vaccinated. As at yesterday, 30th of May, we are at 14.5%. That is low compared to the 49% reported by Sierra Leone, but we hope that by in the next 4 weeks, when the younger population, we just expanded the access to vaccination to include 12 to 18 population in the Gambia. We hope that by the next 4 weeks, when we will vaccinate those that received first dose of Pfizer vaccine, we'll be able to also reach the level that Sierra Leone is now. Challenges in the Gambia, I've mentioned the low uptake of vaccine in other population, and also we also have issues around the individual data capture. Best practices, lessons we learned. We mentioned the best experience using a campaign to reach out to populations. We also noticed that younger populations in the Gambia are more receptive to being vaccinated. And also the older population had preference for vaccines with one dose like J&J. They have preference for J&J to other regimens where we have two doses. So those are briefly what I want to share the experience in Sierra Leone. We hope that by the next meeting, the Uganda will be given an opportunity to come in and share our experience politically. Over, thank you.
Thank you so much. This is exactly the purpose of this conversation, to share across the different countries represented here today. I think we had 50 countries registered to participate in the discussion today. We won't have time for everyone to speak, but I encourage everyone to actually put in the chat, can you give one example of how you reached the elderly in your country? What was the most successful factor? And put that in the chat. And also for Dr. Linda, please continue. Thank you so much for answering all the good questions coming in the chat. If you can continue answering for Sierra Leone, because there are questions about many different things on the communication, on the integration and the effect on routine immunization, and many other pieces that are questioning there. But we also want to hear from Burkina Faso today. So I propose that keep on really being active on the chat. Put your best examples of how you reach the elderly in a short comment in the chat, and we'll all learn from all of us. But now we are actually going to leave the floor to Mr. Zongo Amidou, from Burkina Faso. So over to you for the next country presentation. Thank you. If you can you unmute yourself, Mr. Amidou, so that we can hear you? I can't hear you now, but or the country team. Bienvenue à Burkina Faso. Est-ce qu'on a le...
Oui, bonjour.
Bonjour, bienvenue à vous.
Yes, hello. Hello. Thank you very much. Hello, my name is Mr. Zongo Amidou from Burkina Faso. I'm from the Prevention Department on Vaccination on COVID-19. Can I go ahead? Yes, of course, go ahead.
Box below. So, bienvenue à vous. 20 minutes.
Ok, donc,
Okay, so thank you very much. I'm going to present on the experience that we've had with COVID-19 vaccinations in Burkina Faso. In 2022, the population of Burkina Faso was 20 million. And we noticed that the first cases were notified of were in 2020. Currently, the number of cases within the region, within the entire country, were 21,000. The epidemiological situation as of the 22nd of May, 2022, we had 21,000 confirmed cases, 7,731 of which were women, and 13,286 of which were men. 20,582 of those people received a declaration of recovery, and 386 of them died. That gives us a fatality rate, current fatality rate of 1.8%. Currently, there are about 3 million people who have been vaccinated. So currently, we have vaccinated about 15 to 25, about 15 to 16% of our overall population has been vaccinated. Next slide. So, if we look at the current country situation, our vaccination coverage situation in February 2021, we were able to set up a coverage and to update our plan in October 2021 with an improved NDVP and a mobilization of our vaccines by using the COVAX facilities and also collaboration with other partners. We were also able to be provided 6 types of vaccines that were deployed in the 13 different regions of our country. The launch of these vaccinations with these 6 types of vaccinations through COVAX started in June of 2022. We prioritized the groups of healthcare personnel, our senior population aged more than 60 years, and those with comorbidities. Next slide. Next slide. Next slide, yes. Okay, okay, yes, this slide. Okay, so the strategy that we used to scale up COVID-19 coverage, we were able to organize different vaccination campaigns, specifically surge campaigns. So we use these surge campaigns or intensification campaigns that we did in 3 rounds, in December 2021, January 2022, and April 2022. We were able to extend our vaccination in these surge campaigns to more than just healthcare workers, but to our general population. And we were also able to extend these to all government health facilities. Next slide. Yes, next slide. Yes. Thank you. So the best practices that we use, the first was to identify high-risk groups. And we had a technical expert group who came in for the NITAG, who came in consultation to help us to set up the epidemiological profile of the country. And so we were able to establish prioritization criteria to identify our priority groups. We considered those who were internally displaced in our COVID-19 vaccine data management, and we started to include them in April 2022. The mapping of special populations was set up, but this system still is missing some data. Next slide. We were also able to organize, still in best practices, we were able to organize vaccination days in 70 different districts, trying to reach our priority groups within hospitals, public health facilities. We also visited prisons, places of worship, IDP sites, and institutions. You have to know that we were able to put in a system that really collaborated with different systems, with different community organizations. For example, where we went to administrate different doses, we were able to collaborate with some religious groups, for example, to be able to get outreach into the community. We were also able to extend the search for priority groups by using peripheral health units. We also went to workplaces of public servants and private workers who were also among those priority groups. Next slide. Okay. Can you hear me? Yes. Yes. Yes, please go ahead. We can hear you now. So we're still talking about best practices specific to the coordination and planning. So we were able to put together a COVID-19 task force to be able to access our target groups, and thanks to that task force, so as far as best practices within coordination and scheduling, we were able to put together a COVID-19 vaccination task force who were responsible to find out and to actually gather data, see what the coverage actually was in certain areas, and to be able to propose different actions that people could take, and how we could apply our strategies on a larger level. We were also able to do an interaction review at the national level and subnational level to be able to see how we were doing on our best practices so far, and to be able to share what was actually working in the field. During the different search campaigns, we were also able to have daily coordination meetings and update our information so that we could develop and distribute information bulletins to those groups. Next slide. So during the search campaigns or the intensification campaigns, no, it was the next slide. You were on the right one. It was the next slide. Next slide. It's that one. So we were also able, within the implementation of our search campaigns, we set up a dashboard to be able to monitor performance and to be able to take corrective actions if that was necessary. Then we were able to make detailed updates and disseminate guidelines on the use of the different vaccines and to be able to get those to our sites during the search campaigns on a daily basis whenever there were any updates. And we were also able to develop and update a micro plan really during that campaign. Next slide. So we also went ahead during the month of, before the month of Ramadan, before the fasting period, we were able to do our vaccination in mosques, in markets, and highly populated work areas. Also going to settings where there are internally displaced people like refugees and any areas affected by lack of security. We used the mapping that we did to also help us find those areas and target those groups. As I was speaking of the mapping that we did, we also followed highly populated households and tried to make sure that we got vaccinations targeted to them. We used large events as well during our search campaigns, such as cycling competitions, the Tour Cycliste du Faso, meeting with the president of the youth group, the Youth Association, an Independence Day parade, and use those as an opportunity to vaccinate large groups of the population without necessarily targeting them. We also made sure that we got daily feedback, again, by using the results of sharing the results of the campaign through WhatsApp. Next slide. When it came to logistics and supplies, we tried to identify secondary sites for vaccine supplies so that they could get to health facilities who might not be able to store the vaccines in that cold chain. You know, the thing is that we had to really make sure that we stored the vaccines that had that cold chain facility already set up. We made sure that we kept everything stored in that place. And then we tried to identify secondary sites to make sure that we could then distribute the vaccines on a larger scale to health facilities who might not have as a cold chain storage. And we also did some intra-district redeployment of the vaccines. And we also set up a management committee who contributed in duplicating the vaccine management tools to make sure that everyone was using the same ones. We also used our smartphones for our healthcare personnel or tablets to use them for vaccine data entry. Tablets were great, but sometimes the tablets themselves were not as easy to use for everyone. It was easier for everybody to use their own smartphones. And we also did a weekly update and dissemination of information on the supply that we had. Next slide, please. Yes, and we also tried to make sure that we shared information on vaccination to the authorities by using from the health authorities by using media coverage from the health ministers, members of the government partners, etc. And that really helped us to make sure that people knew that the government was in support. We also tried to develop a guide to manage myths and rumors. At the beginning, we really had to rely on how people were really influenced by a lot of negative rumors, and so we had to really try and manage that. And then also we tried to manage rumors through the use of social networking. We used a lot of activists in social mobilization to, used TV series and such and radio series to try and involve them in dispelling rumors and get people more on board with COVID-19 vaccination. We also used a lot of activists, advocacy workers to really help us with that. Next slide. When it comes to monitoring, yes, slide. Thank you. When it came to the implementation of monitoring, the AEFIs declaring secondary side effects or adverse effects. We had people use a toll-free number as well as electric tools. Then we also had a transmission channel to also be able to share the adverse effects. And we put together a network for focal points to do surveillance. Next slide. For our finances and resources, one of our best practices was by mobilizing financial and technical partners to support COVID-19 vaccination, identifying a budget line supply for COVID-19, and the timely production of a financial report to our partners. Next slide. Okay, the main challenges. As far as coordination, next slide. Okay, that's 2 minutes to finish the presentation. So one of the problems was that there was problems and insufficient national organization. It wasn't functional at subnational level, not enough coordination amongst financial partners, a delay in vaccination data transmission, inadequate numbers of vaccination teams during our surge campaigns. Next slide. When it came to logistics and supply, there was insufficient capacity to be able to have that cold chain storage, really be able to monitor that supply as well, and just be able to store the vaccine for a long enough time to be able to distribute it given its expiration date. Next slide. Generating demand is the greatest challenge that we have seen. There's a lack of capacity to manage rumors against COVID-19 vaccines and vaccination. There's not enough data being communicated, not enough broadcasting on TV and radio programs. Next slide. So just not enough communication. Then there's also a lack of quality control on the COVID-19 vaccination, particularly when it comes to AEFI reporting. That's a real challenge. Next slide. Of course, financial challenges. is really the insufficient financing of NDVPs in general and the delay in disbursement of funds to cover operational costs. Next slide. Just to be able to cover those operational costs, it's really a struggle. So these are some pictures of those who are advocating the healthcare authorities to let them know what the stakes are within Burkina Faso. I'd like to thank them and thank you again. Thank you very much for this presentation, Dr. Kasieta and Mr. Amidou. It was very precise, very specific. You had a really good presentation, and we really understand your dedication and how seriously you take your commitments. We also see that as Sierra Leone did, you used some of the same strategies, such as to go into religious organizations and markets. I am also impressed by some of the ideas you have on the AFIs, specifically the toll-free numbers that you both used. I am very interested in hearing more. But there are a lot of questions in the chat. There's one question from Antoinette who is asking, how were you able to maintain other services during those surge campaigns for COVID-19 vaccination? How are you going to try and improve COVID-19 vaccination services while maintaining all other services? We also have a question that asks, how were you able to implement vaccinations in those insecure zones or unsafe zones? I think that is something, I think that those are the main questions. And then also, there's a question, there's one person who congratulates you for targeting hospitals regarding comorbidities, but what are the strategies that you put in place for older citizens within the community? That's another question. And the José Bier asked, and anyone else? Yes, doctor, could you please answer? All right. You can hear me? Okay, I'm gonna try and I'm here with my team, so I'm gonna try to respond to your question with their help. So regarding targeting older populations within the community and those that are displaced, the strategy that we used advanced strategies as well. So when we arrived within villages, we used sort of a snowball strategy. So we knew that as soon as we got a few of the leaders within the community and respected older people within the community to become vaccinated, then others would then follow. So there you go. Yes, could you speak a little bit louder? Because we do lose you a bit with regards to the sound. Okay. Is that better now? Yes, it's better. Okay, I was saying, when it came to targeting the older population, the advanced strategy we used was really to try and get the leaders, the older people within healthcare senators who really had comorbidities, who couldn't walk or something like that, and use them as sort of role models. And then other people who were in the same situations saw that they did it and that they were okay. Then they would go ahead and get vaccinated themselves. That's, as I told you, was sort of the snowball strategy. in the unsafe zones. So you had to go into those zones every day to kind of see what the situation was on that day. And there were some people in those insecurity zones that really wanted to be vaccinated. They were particularly at high risk. And the original orientation for that strategy was to organize local campaigns within the communities. So they were already ready for us in those zones and kind of provided their own sort of mass protection. So that was the idea. Yes, I would like to add as well regarding in the insecure zones. Can you hear me? Yes, very well. So the WHO, along with the CDC, were also creating reinforcement projects for vaccination in insecure zones. And so the idea was to work with us to identify the leaders in those areas for displaced persons, to work with humanitarian organizations who are already in those areas, to identify leaders, community leaders, you know, who was ever the role models, really the leaders that were helping the displaced persons. And to really find the centers of those communities as a community mobilized action. And that's how we were able to get into those areas, along with the support of the WHO and the CDC. So we were able to do it quickly, but we had to work with the local leaders. The thing is we had to go as soon as we could, as soon as there was an opportunity, because it's true that the level of safety can get worse from week to week. It also depends on the season as to how much access there were. There were 6 areas that were highly affected by lack of security that we had to go into. And we weren't able to go everywhere, but we were able to do what was possible. Thank you. Thank you very much to the entire team at Burkina Faso. We're going to continue now with a closeout message. We have just about 5 minutes until the end of this session. I would like to congratulate Burkina Faso, particularly on the data you were able to gather and the number of people that you were able to vaccinate, particularly in regards to high priority populations. Thank you very much, Burkina Faso.
I would like to give the last words to the ECHO team and to Santosh to finalize and to wrap up. Thank you all for the contributions in the chat and all the rich discussions. Thank you so much.
And thank you very much. And I just in the interest of time, we have a few minutes just to kind of close the wrap session. We have 2 questions as the closing poll questions. If you can get to the questions and request all the participants to respond to the question. So the first question is, have the challenges and the issues faced by the countries faced by the presenting countries also occurred in your COVID-19 focus countries? If you could respond to the question. And if you scroll down on the second question is, these solutions that were discussed and the methods used by Sierra Leone and by Burkina Faso, would it be feasible in your country, in your COVID-19 focus countries?
Santosh, is it the same poll link? Or is it a different poll link? The same poll?
Yeah, it's up on the screen. The link is. And we can see the responses in the screen. Give it just a few more seconds and then we end the poll. And thank you all for your responses. And we can see the responses to the first question in terms of what these the challenges that has occurred in your country. It's definitely yes. 65% have said yes. A 30% has said probably yes, and possibly a 5%. In terms of the solutions that were presented by the countries would it be feasible to your country context? 45% has said definitely yes, 25% probably yes, possibly was a 20%, and no was 5%, and definitely not was 5%. With this, can we go to the next slide? A few more closing remarks before. Next slide, please. So what's next? All the session, this session, the recording will be available in English and French. And for the next session, which is on the 21st of June, the topic that we're going to be discussing is the best practices. Again, we're going to bring two countries, focus a lot of discussions around the COVID-19 best practices, but with an emphasis on integrated campaign and integrated health efforts from these two countries. So we're still discussing and bringing countries for these discussions. But again, a request for all the participants, if there is any good experiences with your country with integrated campaigns and you would like to share it in this forum, please reach out to us and we can have you as the presenter in the next session. For all the participants who attended, thank you for your attendance. A certificate of attendance is available through the University of Mexico. When you do a chat, when you look at the link, you do the survey, a post-session survey, you will obtain the certificate of attendance. An email would also come as a follow-through in terms of the link, and then you can do the post-session survey to kind of obtain the certificate. Next one, please. Next slide, which is the final slide. And in terms of the resources, all of this is going to be housed in the TechNet website. You can see the link on the TechNet page, and then all of the resource materials, including the slides and the narrative, would all be documented and archived there. Just in terms of keeping the community alive, we also have a Telegram channel, which the link is available on the right-hand side of the slide. You can join the Telegram link, and then we will give you notification about the next sessions and more information as countries share the experiences on the COVID-19 vaccination. So please do join the Telegram link as seen in the slide. With this, I would stop. Can you go to the next slide, please? And once again, thank you all for joining, and please reach out to us if there is any presenters that would like to come forward and present the findings for the next session. So over to you, Anne, for closing session, and thank you.
Thank you very much, everyone, for sharing so honestly your both the best practices and the challenges. Let's keep in contact. We have more sessions planned. So warm welcome back. Thank you, everyone, and particularly to all the presenters of today.